business management. He said he will learn business management and do the hospital care service management, something related to administration. He wanted to learn, and he is taking the track in a very good way. People are very clear about it, and your generation are very clear about what you want. So apart from MDDM, there are many options are there. And if you are going to choose the career as MDDM, I would like to tell you that attend postings. Patients are your textbooks. Nothing better could teach you more than a patient. And go to posting. I would suggest don't even cut even single day. You can cut the theory class, you can cut the practical class, no problem. You will not lose anything big. But attend the postings, clinical postings. And this, in your generation, there are a lot of teachers who are willing to teach you. There are a lot of youngsters who are excited about finding new cases and presenting and showing it to many people. And I find that you students should utilize the opportunity. And the only hindrance of you students I find is you form a circle around yourself because of your present exposure, or I don't know, I may be wrong also. Because of your peer pressure around, because of your exposure around, you are forming a limited circle around yourself. What I would suggest is come out of that circle. Look outside beyond what you are seeing. That's what I would suggest. And this clinical postings, one day it might be boring for you. Even to all my students, to even Priyanka batch, I think 2019 batch, when they joined, the COVID started. I did not have much exposure to 2019 batch of MMC. I think all of the faculties in Tamil Nadu have the same thing. And 2018 batch was my first batch when I joined. So to their batch, I would have said lot more things. I always say this, just like getting up in the morning, brush your teeth, taking bath, and coming to college. Whether you take bath or not, at least we brush our teeth, right? So just like that, when you enter the ward, see every patient, single patient, look for their pulse, auscultate, both for the breath sounds and heart sounds. Even if it is every day, do it. Even if you know that Austin Flint murmur is for aortic regurgitation, it's okay. Even if you know, it's okay. Go auscultate that murmur every day till you finish your posting. It should come as a reflex to you, because you have this wonderful opportunity of learning with the patients only till you are in CRRI. Once you leave this college, after that you can't even enter to your own college, you cannot enter into any ward, you cannot touch any patient. And to all the government medical college students, I one thing I would tell is, you are lucky you are in a government setup. There are thousands of patients overflowing in government setup for service, treatment, management, investigations for their own treatment. Complicated cases are coming, and MMC, I would say, uh, the students are not utilizing the resources of MMC properly. That's what I would say. Most complicated cases, the rare cases that we study in textbooks, are there coming to your doorstep. The only thing is you have to go and see the patient. See, when will you know that, for example, Lauren Moon Biddle syndrome was there in pediatrics, ICH ward? And I know it. Even last month and before month, it was there. When Lawrence mean, how many of you have seen that case? Last month it was there. The patient was discharged only last week. How many of the students in MMC know that Lauren Moon Biddle syndrome was there in the unit? Somebody should go in that unit, should convey the information to you, right? So if that unit has to students has to convey information to you, then they have to go there regularly. So go to posting regularly. If you come across any cases, rare cases, tell your friends, tell your colleagues, tell the whole batch, so that everybody can go and see that case. So make it as a regular thing. It is must. And as per the curriculum and medical profession, and I think medical education has now become business. The moment this NEET exam, exit exam has come, it has become business. It is no more an education. That's what I could say. All of you are going to be manufactured by one group of entrance group of people who are, I mean, a group of people who are preparing you for entrance, and they will push you into MD and DM, like how you are entering into MBBS. The quality, I'm worried. I'm worried right now because after 10 or 20 years, if I have any cardiac problem or anything, I have to come to you. Somebody in this group out of 63 participants is going to be a cardiologist. When I come to you, I'll be first question that will strike my mind is, can I trust this cardiologist? That fear is there for all of us because the quality of MBBS is going down somewhere along the lane. And your generation, I think it's in the right generation. Your generation is in the right time to set it correct. That's what I could say. And clinical postings is must. How much ever you see, you read, I see in MMC Stanley, and there are a bunch of students who are behind quizzing and identifying Noonan syndrome with short arm chromosome mutation or long arm chromosome mutation, which exon is deficient. What I would like to suggest is Noonan syndrome, we will never see in India at all. It's an congenital condition which is frequently seen in Western countries. We don't even see. Why to read that? There are a lot of cases, congenital cases we see here. Fanconi anemia is a congenital Fanconi anemia is coming, at least 2 cases are coming every week in pediatric department. Go and see that. There are a lot of syndromes and complicated conditions which are coming to GH, and the doctors, physician, pediatricians, a team is working to save the child. The team is working to save a child with leukemia or its complications. Go and learn that management, how leukemia is such a complicated case is getting revived. Learn that because that is what will make you a better person tomorrow. All these things your textbooks will not teach, because here a bunch of pediatricians, they are having an expertise, they are seeing a case, they are following a protocol which is given in the pediatric textbooks. That is not working. So they are changing the protocol with their understanding analysis of the clinical finding, and it is working out, and the child is saved. The life of the child is saved. So this is happening here. So you go and learn that. Who will teach you? Textbook will not teach you. Harrison is written by a foreigner, not by an Indian author. Nelson textbook of pediatrics is written by a foreigner, not by Indian authors. We have a lot more expertised Indian physicians. Learn from them. So if you want to learn from them, you have to go and listen to their teachings. So go there. Go to postings. Learn from your own doctors. According to me, in Tamil Nadu, out of all the states in the country, we have the best of physicians. In all the medical colleges, the best of physicians are there. In medicine unit, if you go to surgery unit or some any unit you go, you will come across some chief or professors doing for rounds. Go for the rounds, attend the rounds, and they will be in each rounds for if in a ward, for each round they will be discussing about a particular patient. They till the patient get discharged, they will discuss what they did yesterday, what is the management today, what will they do tomorrow, and when will the patient be discharged. Follow up. When you enter a ward, attend the rounds. You will um, learn the course of the patient. I mean to say, in COVID time, we were all working. You know how we worked. Once a COVID patient gets admitted, I will know the complete details since the day the patient and got admitted in the ward. If in ICU, all the doctors were like that. I was feeling so happy how all of us were like that because we all were trained like that. When I did CRRI, forget about CRRI. When I was doing second year posting, we are supposed to attend the OP at 6:30. 6:30 the attendance will close. They will give a spare time of 5 minutes or 10 minutes. 6:40 it will close. That's all. After that, if you come late, we never went back. Even if we come late, even if we have absent, we will go and stand in the OP and we will listen. Because my unit was M1 at that time, we had the best of professors at that time. Dr. Chandrasekhar was there, Dr. Murali was there, and all professors, all assistants will be there teaching every single finding. The next day they will ask, yesterday patient Shaktivel came. What is the diagnosis, doctor? This is what they will ask. So we will be keenly observing which patient is coming, which with what diagnosis. So even if they mark absent, we won't leave that OP because that is what our seniors taught us. Our seniors said, "You M1 unit is the best unit. Don't miss even a single day. Even if they mark absent for you, stand in the OP. That is where you learn." The senior junior interaction will be towards learning. They will tell us where to go, how to be, and that pattern also has been changed now. The senior junior interaction in your setup, all I could see is totally different. Even uh, I think things are changing. We have to go with the change. I don't know, but attend postings, go early, attend the OP times. Even if somebody tells you why are you coming, it's okay. Nobody has to teach you. Patients are there, you are there, you have the stethoscope. Get your own BP apparatus. Go and record the BP of the patients. Auscultate, take history. There will be minimum 50 to 80 patients in one ward, at least 60 patients in one ward. You have 60 patients to study one day. Even 15 days not enough to study the whole 60 patients. Every week the patients will be discharged, some other new patients will come. You don't have time to study already. And how many of you are already studying the patients in the ward? How many patients have you read per day in the unit that you are attending now, right now? Think about it. Actually, you have lot of works to do. You have lot more to learn. Don't waste time. All these are very precious time. You won't get it back again. And I still remember in CRRI when we were doing CRRI also, and OG in OG posting in every batch to every batch I say in OG posting in Tanjavur there is a thing called if a girl baby is born, they will try to kill the baby. So in my time now it may not be there, but we wanted to prevent. As CRRS we want to protect, so we all batchmates whoever is free will come for the labor ward. We will we will give extra care for the baby child, and we also will monitor for pre-eclampsia and eclampsia patients. They will be very anemic and they will not have their hemoglobin will be 5, and they might not have sufficient hemoglobin for either for delivery or cesarean. They'll get complicated. I still remember, even if I'm not there in the posting, I will hand over that case to the next my batchmate. I say this patient is there, take care, and till the patient gets deliver delivers the child either by normal or cesarean, I will follow up the patient till the patient get discharged. So patients will always remember us during our CRRA.